Okay, welcome back to Section 2. Before I proceed on to the NRP algorithm, I just wanted to clarify that I know that you may be confused as to the fetal circulation because we are so accustomed to arteries carrying deoxygenated blood and veins carrying oxygenated blood. However, because of the bypass of the lungs, fetal circulation, and the baby being able to oxygenate itself, that is the reason for the flip. If you have any confusion or question, we can go ahead and review that in the class for you. So if you have any questions, you can ask them then. So now what we're going to do is we're going to go ahead and go over the NRP algorithm. First, I just want you to note that in the algorithm there is several different blocks. Some of the blocks are rectangular and some of them are diamond-shaped. The diamond-shaped blocks are going to represent an assessment that needs to be made, whereas the rectangular blocks will represent an action that needs to be taken. I can't stress enough that you need to complete whatever is in the current block before proceeding down to the next block in the algorithm. So what we're going to do in this section is we're going to review the team briefing and the equipment that we need before any delivery. And then we'll go through a delivery where the baby is stable enough to go with the mom prior to transport to another hospital. So, team briefing and equipment check are first on the top of the list of the algorithm. They're in the first rectangular block, so it is an action that we have to take. During the pre-resuscitation briefing, what we will need to do is try to ascertain any perinatal risk that will affect how we care for the infant. We may or may not be able to gather this information depending on the condition of the mother or the prenatal care of the mother. But these examples of these would be drug use, heart conditions, diabetes, and the like. We also need to assign a team leader for the baby. Now, assigning the team leader for the baby needs to be done carefully. The team leader needs to be someone that can focus on the entire situation of every task that's going on in the room during the resuscitation. The team leader cannot get bogged down with one particular task, thereby not being able to delegate other tasks that may need to be done simultaneously. So this is what we call situational awareness. So the team lead needs to be aware of the entire room and all the tasks that are going on relative to the care of the baby. The team leader needs to be able to delegate these tasks accordingly. We need to identify who will document. We are going to be delivering babies in an emergent situation almost always. In a lot of these circumstances, these babies will not be term. So we need to make sure that we are documenting comprehensively and thoroughly everything that is going on during the resuscitation. And then we need to, of course, determine what supplies we are going to need. This supply list or equipment list will be available to you. It's actually on the giraffe currently. It will go through many of the actions we will be taking during the resuscitation efforts and break them down a little further. I'm going to go through the equipment list one activity at a time. So first, we're going to focus on how we warm the baby. Of course, we have the giraffes in the emergency department. We need blankets. We need the blankets not just to warm the baby, but also to dry the baby off. And we need to remove the blankets whenever they are dampened or wet. We need stockinette caps. This will be found in our neonatal cart that will be rolled into the room. We need a thermal mattress. The thermal mattress is a temperature regulated mattress that will go under the baby So heat regulation will come from both below the baby and from above the baby on the radiant warmer. We also need a plastic bag or plastic wrap. We use this for babies that are 28 weeks or less or small for gestational age. One thing that I don't have pictured here is the little temperature sensor that we're going to be putting on the baby, and we need to make sure that we do put this on the baby and connect it to our giraffe, because we're going to be using the manual setting for temperature regulation on the giraffe, allowing the machine itself to regulate how much radiant heat comes out of that warmer and the thermal mattress below. Babies are very sensitive to heat, and because of the thinness of their skin and the translucence of their skin, the heat production really needs to be monitored closely, and having the safety mechanism within the giraffe regulating the heat according to the baby's temperature is the safest and best practice to follow. We need to clear the airway. We will be using a bulb syringe to clear the airway. With the bulb syringe, we will suction the mouth first and then the nose. We will need a suction catheter available. We will need suction setup. We will need a meconium aspirator in the event the baby has meconium in the amniotic fluid. As you know, meconium is a bowel movement pre-delivery in the amniotic fluid, turning the amniotic fluid from clear to either a greenish or a brownish color. We'll need to auscultate the chest of the baby to listen to the lung sounds. And we're going to auscultate on the left side of the chest, and we're going to use a neonatal stethoscope. In order to ventilate the baby, we are going to need a flow meter with oxygen. We're going to need a bag mask with the proper size mask for the infant. We will also need an oxygen blender, which is currently set up on the giraffe as we speak. We need an orogastric tube in the event that when we're ventilating the baby, the oxygen gets trapped into the abdominal cavity and the stomach. In order to oxygenate the baby, we will need tubing for free flow oxygen. In order to deliver supplemental oxygen, you can actually use the tail of the ambu bag that we have available to deliver the free flow oxygen. We will need an O2 sensor for the baby, and definitely a list of the preductal SpO2 target levels in the baby. As you remember, during the circulatory discussion pre-delivery, that the baby is sustaining somewhere around 60% oxygen level in the blood during intrauteral life. So now when the baby is born, we cannot be as aggressive as we would with a child or an adult. We need to gradually increase their SpO2 level, and those target levels with the corresponding minutes are very important in order for us to not hyperoxygenate the baby or cause a pneumothorax or whatnot. So this is very important that we focus. The hallmark goal is 90 at 9, 90% at 9 minutes. So it's really important on that giraffe that we set that timer as soon as the baby is delivered, so that we know what our preductal SpO2 targets are as we are caring for the neonate. We will need intubation blades. We will generally be using a Miller blade because of the shape of the neonate's trachea and esophagus. We will be using an ET tube, and the sizes are located both on the equipment list, and we will go through them when we go further into intubation. with a stylet. Some practitioners do not use a stylet. It is not necessary, but we do have one available in the event that they do need the stylet. We need a CO2 monitor to make sure that we are in the right place once we do intubate the baby. We also need some type of measuring tool to determine how far down the tube needs to go. And of course, we need tape and scissors to make sure that we secure the ET tube in a place once we have established placement. I also have up here a laryngeal airway. We use these airways in the event that it takes too long. Optimally, intubation should take 20 seconds or less. Sometimes we can't intubate because of swelling or anatomical deformities, so we will need to use a laryngeal airway, and we will discuss inserting that later on down the road as well. And then, of course, the last effort that we're going to participate in a resuscitation is, of course, medication. We need to make sure that in our neonatal carts that we do have 1 to 10,000 ratio epinephrine. The regular carts have 1 to 1,000 ratio, so it is quite a difference in the dosage. We need some normal saline. We may be giving some fluid expanders or need to flush lines, so we will need normal saline. We will need syringes. I have pictured here 3 cc syringes, but for epinephrine it is best to use a 1 cc syringe because of the dosages that we will be giving the baby. We need a setup if the practitioner would like to insert a umbilical venous catheter line, and we will need leads for EKG monitoring. So now you have all of your equipment ready. You've decided who your team leader is, and you've decided everyone's role post-delivery. What questions do you ask prior to the delivery? Well, the first question you ask is, what is the expected gestational age? The second question is the amniotic fluid clear? This may guide our respiratory efforts down the line if we know that there was a meconium delivery or meconium staining in the amniotic fluid. So we need to know how many babies we're expecting, and if there are any additional risk factors that we need to know about. So the 4 pre-birth questions are: what is the expected gestational age? Is the amniotic fluid clear, or are we dealing with a meconium delivery? How many babies are expected? And are there any additional risks that we need to know about? So the baby's born. What are the questions we now ask? Does the baby appear to be term? Is the appearance of the baby coinciding with the gestational age that you received in your pre-birth questions? If the baby's term and appears to be very small, is this actually a term baby, or is it a small for gestational age baby? If the baby appears to be preterm, we need to go ahead and bring the baby over to the warmer. We need to continue our assessment there, especially if the baby's having difficulty expanding their lungs or establishing good respiratory effort or maintaining a body temperature. It's best that we have the baby under the radiant warmer so that we can sustain that temperature. Preterm babies are much more likely to deal with temperature issues than that of term babies. Next question we need to ask: does the baby have good muscle tone? This is a quick observation. Healthy babies should be active. They should be flexing their extremities, their upper and lower extremities. Newborns requiring any intervention are going to be flaccid. Their extremities are going to be extended out, or they're just going to be no voluntary movement displayed by the baby. And the third question is the baby breathing or crying? A vigorous cry is a clear indicator that there's a strong respiratory effort. If the baby is not crying, observe the baby's chest for breathing effort. Don't be misled if the baby is breathing but gasping. Gasping is a series of deep or single stacked inspiration that occurs in the setting of severe gas exchange impairment. A gasping baby requires intervention and must be brought to the radiant warmer. So, for this section, all of our answers are yes. So, what do we do? The baby appears to be term. The baby's extremities are moving about. The baby's crying and appears to be breathing very well. Then we can go ahead and give the baby over to the mom for routine care. We need to make sure until the baby and the mom are transported to another facility from here that we maintain the temperature of the baby, that we reposition the airway if there's any difficulty, if we note any difficulty breathing, if we notice any difficulty breathing. We need to clear secretions out as needed, and we need to make sure that the baby is dry, and just continually evaluating this until we can get the baby to a hospital with a nursery and a pediatrician or neonatologist, whichever the case may be.
The role of medical personnel is to monitor and support normal transition, foster continuous contact between mother and infant, and initiate early breastfeeding.
So you see, with a healthy baby, that is our role. We're trying to foster the relationship between the mother and the baby. We give the baby back over to the mother as soon as possible. This may be before or after transport. But with a healthy baby, our priority is to establish that mother-baby bond as soon as we possibly can. In the next section, we will be talking about deliveries that aren't as easy and can't go directly to the mother based on the condition of the neonate post-delivery.